Dear colleagues, here's the first case of a patient having IFIS and zonular weakness. Viscoelastic is now being injected into the anterior chamber, allowing us to expand the pupil, which is moderately dilated. By pressing with the cannula on the anterior lens capsule, we can see folds, which is a characteristic sign representing zonular weakness. Size of the pupil is about 5 mm. And of course, we will need pupil expansion device in that case. We will be using Malugin ring in the classical version. With the injector, we are inserting that device inside the anterior chamber, catching the iris with the 3 scrolls of the device and utilizing the ring manipulator to insert the last scroll located close to the main incision. Capsulotomy was done with the femtosecond laser. Also, 3 capsular hooks were inserted to stabilize the equator of the capsular bag and help the zonules to support the capsular bag in place. Final steps of nucleus removal. We still see that there is a possibility for the capsular bag to collapse in spite of the presence of the capsular hooks. That's why CTR is now implanted into the capsular bag to keep the equatorial contour of the capsular bag, and then IOL is implanted inside the lens capsule slowly. With the help of the injector, I'm positioning the IOL inside the anterior chamber and manipulating the trailing haptic, placing the device into the correct position. In order to disengage the ring from the iris, the manipulator is utilized. The ring is rotated slightly counterclockwise to help with the disengagement of the scrolls, and the same injection device is used to retract the ring from the anterior chamber, and I'm helping myself with the side port instrument to allow the ring goes completely inside the injector tube. And this is the end of that case, and the pupil constricts spontaneously. The pupil that constricts during the procedure is the characteristic signs of intraoperative floppy iris syndrome. It will now be presented in the second clinical case. At the beginning of the surgery, we have a pupil of about 5.5 mm, and after creating capsulotomy and releasing the gas from the capsular bag and performing hydrodissection, phacoemulsification is now being done following the cracks performed by the laser energy. During the procedure, we can see that the pupil starts to constrict, which is not infrequent case in patients with intraoperative floppy iris syndrome. The attempt to stabilize the iris tissue and expand the pupil was done with the help of viscoelastic, however, with limited effect. The manipulations were done mostly at the very center of the anterior chamber to avoid catching the iris. However, sometimes it is possible, and you have to be quite careful not to damage the iris with ultrasound. At that point, the decision was done in favor of pupil expansion device, and the Malugin ring is now injected into the anterior chamber. In these cases, specific care should be taken not to catch the edge of the anterior capsule, because capsulotomy can be easily engaged with one of the scrolls of the device. Now, when the pupil is expanded and the cortex material is exposed, it is quite easy to aspirate it utilizing any of your preferred technique. Following the IOL implantation, the device is removed from the eye with the help of the injection device. as shown on this video fragment. And this is basically the end of that case, which was finished successfully. Our next case represents the situation when the pupil was small at the very beginning of procedure, and as shown here, the surgeon decided to proceed with capsulotomy, which is done with the microcapsulorhexis forceps, following the contour of the iris. It was possible to create a reasonably sized anterior capsulorhexis opening. After completion of the capsulotomy, the size of the pupil was measured, and as we can see here, this corresponds to 4.5 millimeters. Sufficient hydrodissection is very important to mobilize the nucleus. It is specifically useful in small pupil cases. The decision was made in favor of implantation of the pupil expansion ring, which is now being done by placing the device inside the anterior chamber with the specific injection device. I disengage the device from the injector and utilizing manipulator to catch the iris margin in order to fixate and expand the pupil. Again, we have to be quite careful in order to avoid catching the capsulorhexis edge, which can be easily done by the scrolls of the device. So you have to have a look at the mobility of that device, and if there is any place of movement restriction, then this will give you an idea of whether or not you are catching the anterior rhexis, which happens in that case with the scroll located contralaterally to the main incision. And I am now disengaged this scroll in order to facilitate further steps of that procedure. Again, I'm checking now the mobility of the device, and it looks like it's moving freely, meaning that the placement of that device is correct. Phaco chop with the manipulation at the very center of the anterior chamber are my favorite because you're actually not going behind the iris and manipulating in the very center of the capsular bag. Bimanual irrigation aspiration is being done to evacuate the residual cortical material from the capsular bag. Final steps of cortex evacuation and capsule polishing are now being done, and we can see here that the capsular bag is slightly mobile. Specifically, posterior capsule is mobile, representing weakness of the zonular apparatus of the thigh. Viscoelastic is injected into the capsular bag, and then we realized that the proximal scroll of the device was catching the capsule. It's now being released, and IOL is implanted into the capsular bag with the help of the injector. It passes the pupil. Now I'm inserting the haptic of that IOL into the capsular bag, positioning it in the right direction. Slight rotation may help me to assure that the both haptics of the device are in place, and now I'm disengaging the scrolls, first contralateral, then located nearby the incision, and I will be releasing the last scroll right now, and will use the injection device to retract the Malugin ring inside the injector tube and remove it from the eye. After viscoelastic evacuation from the capsular bag and the anterior chamber, the case is completed, and I thank you very much for your kind attention.